everyone, my name is Faustine Ramirez and I'm a master tutor with MedSchoolCoach, and today we'll be reviewing a Step 2 CK medicine question. So let's start by reading the stem. A 12-year-old boy with a new diagnosis of ALL is admitted to the hospital for chemotherapy induction. On day 2 of the hospitalization, he starts complaining of tingling around his mouth. He also reports cramping of his hands and feet. He feels anxious and very fatigued. He last voided 8 hours ago. Temperature is 37.3, heart rate is 122, respiratory rate is 20, and blood pressure is 118/73. On examination, he has generalized mild muscle weakness and periodic spontaneous muscle twitching. Laboratories show the following labs. EKG shows a PR interval of 220 milliseconds and sharp pointed T waves. He is receiving 2 times maintenance IV fluid hydration. In addition to IV fluids, which of the following could have helped prevent the renal dysfunction? So I'd like you to pause the video for a moment and try to work through this question on your own first. All right, welcome back. So let's approach this question together. As always, we start by reading the very last sentence to understand what the question is asking us specifically. So in addition to IV fluids, which of the following could have helped prevent the renal dysfunction? So this is a very specific question. It's going to be a question about prevention or prophylaxis. So we will have to identify what the diagnosis is when reading the stem and then answer a specific question about that diagnosis. But it's also very specific in that it's not asking us how we would have prevented the entire presentation, but it's specifically referring to the renal dysfunction. So sometimes you will get questions like this where there are multiple different components of the management, and so you're getting asked a question about a specific part of the management, not the entire management itself. And so as you're going through the answer choices, you might see multiple answers that seem correct, but you have to really focus specifically on what aspect of management you're being asked. So here, this is a question specifically about renal dysfunction. And so we will have to identify the diagnosis, but when we're thinking about the answers, we want to specifically focus on preventing renal dysfunction and not just preventing the entire condition or presentation. So we glance at the answer choices and we just take a few seconds to look at these, and they involve a number of medications. And so it's going to be focused on identifying the appropriate pharmacology. And that's kind of all we need to take away from glancing at the answer choices. Once we look at that, we know this is going to be, we'll be having to pick a medication. Then we read the question stem from the start and we'll highlight the key elements. So a 12-year-old boy with a new diagnosis of ALL is admitted to the hospital for chemotherapy induction. On day 2 of the hospitalization, he starts complaining of tingling around his mouth. He also reports cramping of his hands and feet. He feels anxious and very fatigued. He last voided 8 hours ago. Temperature is 37.3 Celsius. Heart rate is 122, which is on the higher side for a 12-year-old, so some mild tachycardia. Respiratory rate is 20, and blood pressure is 118/73. So I recommend highlighting the abnormal vital signs in all questions. On examination, he has generalized mild muscle weakness and periodic spontaneous muscle twitching. I also recommend highlighting abnormal examination findings as you're reading through your question stem. Laboratory studies show the following labs. So before we even take a look at the labs, I think it's important to highlight the abnormal findings on the presentation and try to focus in on those elements that are very specific. So although I did highlight fatigued because it mentioned he's very fatigued, so that could be helpful, but in general, things like fatigue, abdominal discomfort are pretty non-specific, so I think it's important to pay attention to them, but they're not going to make or break the question in terms of figuring out what the right answer is. So try to focus in on those very specific elements, both in the history and then also on the vital signs. So highlight the abnormal vital signs. Those are going to be important key elements. And the physical exam findings that are abnormal, I would also highlight those. Similarly, when we look at labs, especially for these questions with a long list of labs, I don't want you to waste time continuously referring back to the reference ranges. So I think it's important to always compare the lab value to the reference range unless you're 100% sure you know what the reference range is. But oftentimes in the setting of a test, it's sometimes easier to just check it. Once you check it, I want you to highlight the abnormal lab findings, and it's best to develop a system to help you remember whether it's elevated or decreased. So some students like to highlight the right side of the value if it's elevated and the left side of the value if it's decreased, or some other system. They like to underline it. Just partially develop a system, but just be consistent so that once you compare that lab value to the reference range, you never have to go back and check it again. You never have to waste that time again because this does take a lot of time. So check it once, highlight it if it's abnormal, either remember or write down or develop a system to remember if it's abnormal in the up direction or the down direction, because that's important too, and then never refer back to those reference ranges when you're reviewing the question stem. So we'll go through here, we'll highlight the abnormal ones. I personally like to highlight the right side when it's elevated and the left side when it's decreased, but you can just develop a system that works best for you. So sodium's within the normal range, potassium is elevated at 6.2, chloride also within the normal range, creatinine is quite elevated, especially for a 12-year-old, glucose within the normal range, phosphorus is also elevated, calcium is decreased, so we will highlight the left side, bicarb is on the lower end of normal, but not too drastically abnormal. BUN is also elevated, and uric acid is also very elevated. So we have a number of electrolyte abnormalities here. Then we keep reading. EKG shows a PR interval of 220 milliseconds and sharp pointed T waves. So you won't always be told that the PR is short or prolonged, but you might just be given the duration. So it is important to remember your reference ranges for your EKG intervals. So the PR interval shouldn't be any longer than 200 milliseconds, so that's 5 little boxes. And the QRS shouldn't be longer than 120 milliseconds, and that is 3 little boxes. So I would remember those two numbers, 200 for PR and 120 for QRS. And then sharp pointed T waves, these are obviously also abnormal. He's receiving 2 times maintenance IV fluids, and then we have the question. So for these long question stems with a lot of labs, a lot of findings, I think it's really helpful to, before we even look at the answer choices, to pause the video for a moment and synthesize what we have read. So let's take a moment to do that. And the idea here is to synthesize what the key elements are from the stem, to put those pieces together, to be able to identify the diagnosis, and then to be able to answer a specific question about that diagnosis. So putting these pieces together, we have a patient with a new diagnosis of ALL, starting chemo. And it's day 2 of chemo. His symptoms of tingling around his mouth and cramping, as well as the generalized mild muscle weakness and muscle twitching. So these are consistent with one of the electrolytes that's very abnormal. So you should be able to identify these elements of muscle twitching, weakness, as well as also the fatigue and anxiety in the setting of these electrolyte abnormalities. You should be able to put 2 and 2 together, that these are clinical manifestations of the low calcium. So we have both lab and clinical evidence of hypocalcemia. And you should be able to recognize these findings in the future. These are the physical exam findings that are consistent with hypocalcemia. So twitching, tetany, could be weakness, fatigue, anxiety. Those are all seen in hypocalcemia. And so you should be able to recognize that in future questions. That's definitely a high yield learning point. So we have hypocalcemia. Looking at our other abnormalities, we have hyperphosphatemia, right? We also have hyperkalemia, and we know that when we look at our EKG findings, more classically we learned that sharp pointed T waves or peaked T waves are consistent with hyperkalemia, but actually prolongation of the PR interval is as well. So both of these EKG findings are consistent with hyperkalemia. We also have other lab findings of hyperuricemia. And finally, this question is about renal dysfunction. So that is consistent with the patient's creatinine and BUN. So the creatinine is 1.9, which is quite high. We have an elevated BUN as well. So both of these are consistent with an AKI. So now that we've put all of these pieces together, we're able to see kind of what the overarching theme is, the pattern that emerges from all these elements. So putting all of these pieces together, these electrolyte abnormalities and exam findings that go along with them, as well as the AKI in the setting of a patient who recently started chemotherapy for a new diagnosis of ALL. This is a classic pattern that you should be able to recognize for the boards, and that is a pattern for tumor lysis syndrome. So tumor lysis syndrome, we'll talk a little bit more about that, is definitely something that you could be tested on. It's a complication of certain oncologic processes. Several malignancies are increased risk of developing tumor lysis syndrome, and we'll discuss those in a moment. And so before we even move on to the answer choices, I think it would be helpful to cross a few of these out that we know are wrong, and then we'll come back to learning about tumor lysis syndrome and identifying the correct answer. So now that we know what the diagnosis is, then we're asked to answer a specific question about that diagnosis. So this is really when focusing in on the specific point of the question, the specific topic of management is important, because you might be quick to see that there's hyperkalemia, right, and peaked T waves. And so you might want to jump to the management of hyperkalemia, right, which you know would be giving calcium gluconate, for example, to stabilize the cardiac membrane, or even calcium chloride. So one of these could have been correct if you were, you didn't really pay close attention to what the question was asking you, and you might say, oh, this is a management question, this patient has hyperkalemia with peak T waves, let's treat that. But that's actually not what this question was about. That's why paying attention to this question is so important and so crucial. So we can cross these out, because those would be correct for if the question was about management of hyperkalemia, but they're asking us something different. Otherwise, the rest of these we can leave for now, because we need to review what the management of tumor lysis syndrome is and how we prevent it. So let's hold off on these for a little bit. I would say the only one that we could potentially cross out before learning more about tumor lysis syndrome is potentially furosemide C. And that's because we have a patient who has evidence of acute kidney injury. And so we would want, although we haven't quite yet identified the cause of that acute kidney injury, we would want to avoid diuresing that patient to prevent further kidney damage. So I would say that one is not consistent either with the question that's asking us how we would prevent renal dysfunction, because we know that Lasix has a tendency to diurese patients, and that can actually cause more kidney dysfunction. All right, so let's learn a little bit more about tumor lysis syndrome in order to correctly identify the answer among the remaining answer choices, which are colchicine, resveratrol, sodium bicarbonate, or allopurinol. So let's take a look and learn more about tumor lysis. So tumor lysis, as I mentioned, is a complication, an oncologic complication, and it's due to the rapid destruction of tumor cells, which leads to massive release of intracellular content. So you remember that that includes potassium, that includes uric acid, that also includes phosphorus. This usually occurs within 1 week of initiating chemotherapy. And although it can occur at any time, it typically is within a week of initiating chemo. And the highest risk for tumor lysis is certain cancers, including ALL, AML, Burkitt, or large cell lymphoma, so non-Hodgkin lymphomas. It's a much lower risk with solid tumors, for example. And it has specific features that are associated with the electrolyte abnormalities that define tumor lysis syndrome. So the presence of hyperkalemia can lead to arrhythmias, including peak T wave, prolonged PR interval, and eventually more severe arrhythmias, including ventricular arrhythmias. It also releases phosphate from the intracellular contents, and so you can get hyperphosphatemia. And the phosphate, the most important thing that the phosphate does in terms of the manifestations of tumor lysis is that it binds calcium, and it forms these calcium phosphate crystals that can obstruct the renal tubules and lead to an AKI. Now, you can also get an AKI from uric acid crystals because of the hyperuricemia, and the hyperuricemia is from the nucleic acid breakdown. So those tumor cells break down, you get all of these nucleic acids, purines specifically. The purines break down and create uric acid, and we'll look at the metabolic pathway for that in a minute. And so as these tumor cells break down, they release all of these components, including nucleic acids, and those get broken down into uric acid. And then the uric acid precipitates into crystals that also obstruct the renal tubules and lead to an AKI. And so this picture here shows the uric acid crystals that can be identified in the urine. So I would be able to recognize this picture in case you get a similar scenario, but maybe less information, but you are given a picture of the crystals found in the urine. So these look like uric acid crystals. So I would be able to recognize these in case they do show up on your exam. Finally, you get hypocalcemia from phosphate binding the calcium, and the hypocalcemia can develop, can have clinical manifestations that are seen with hypocalcemia, so paresthesias, cramping, weakness, tetany, fatigue, anxiety, seizures. You might get the Schwostek sign. All of these findings that you classically associate with hypocalcemia, you can get in tumor lysis syndrome because the phosphate binds the calcium and leads to quite low levels. So this is the pathway that I was mentioning earlier. So your purines, adenosine and guanosine, break down into xanthine, which is converted into uric acid, which remember is insoluble. And the enzyme xanthine oxidase converts xanthine into uric acid. And so when we're thinking about management, one of the cornerstones of tumor lysis is prevention. So the idea is to prevent this from happening before we get all of these complications. So aggressive maintenance fluids is really important. So typically it can be 1.5 or even 2 times maintenance fluids that these patients will be on, and we watch their urine output very closely. So in the question, the patient who had not voided in 8 hours despite being on 2 times maintenance fluids is consistent with his kidney injury and is very concerning, because someone who's getting that much maintenance fluids should be having really high urine output. And to prevent uric acid production, so to prevent the conversion from xanthine to uric acid, we want an inhibitor of xanthine oxidase. And so you remember from pharmacology that allopurinol can prevent uric acid production because it inhibits xanthine oxidase, right? So allopurinol inhibits xanthine oxidase, prevents xanthine from being converted to uric acid. If it's too late and you already have really high levels of uric acid, then what you can do is you can actually give rasburicase, which converts uric acid into allantoin, which is water soluble, so it can be excreted. So in terms of management, we have allopurinol that can prevent uric acid production, and then once we have really high uric acid levels, we can then convert it into a water-soluble form by giving rasburicase. So rasburicase is for the treatment, allopurinol is for the prevention. And then finally, if you do see hyperkalemia and signs of EKG changes associated with hyperkalemia, you also want to treat those, right? Because those can be an emergency. So remembering your C big K for treatment of hyperkalemia with calcium gluconate to stabilize the cardiac membranes, that would be kind of the first step that you would do, and then you would try to drive the potassium into the cells. And so if you don't remember the management of hyperkalemia, now is a great time to review that because it can come up in questions about tumor lysis management, and it could also just come up on any question on the board, so that's a very high yield topic. So in terms of management, we have both prevention and treatment. So let's go back to our question now. And so as I mentioned, the last void 8 hours ago in someone who's getting 2 times maintenance is consistent with a kidney injury, the creatinine of 1.9 and the BN of 30. And so now that we have identified that this is tumor lysis syndrome and we have learned about the management of tumor lysis syndrome, we can go through these other answer choices. So we've already crossed off A, B, and C, and then we're left with colchicine, rasburicase, sodium bicarbonate, and allopurinol. So you may remember colchicine as being part of the management of gout, which is related to uric acid. So it was there to kind of try to distract you as a red herring, but it's not going to be first line in the prevention of renal dysfunction in tumor lysis syndrome. So we can cross that one out, as well as sodium bicarbonate. Previously, alkalinization of the urine was part of the management of tumor lysis syndrome, but it's not at the forefront of the management anymore, and it certainly would not be how you would prevent the renal dysfunction specifically. So both G and F were related to hyperuricemia and potentially tumor lysis syndrome, but they weren't actually part of the direct management for the prevention of renal dysfunction. And sodium bicarbonate is not really used anymore. So that was also there as a red herring. So G and F were there as red herrings in case you didn't exactly remember how to manage tumor lysis. And so they were there to try to trick you. And so then we narrow it down to raspberry case or allopurinol. And so this really hinges on your understanding of that pathway that we were looking at here. Is if you understand that allopurinol inhibits xanthine oxidase, and xanthine oxidase is important for the production of uric acid, but that rasburicase is actually important for the conversion to allantoin, then you can realize that rasburicase is more for treatment and allopurinol is more for prophylaxis. And so this question specifically was not asking about treatment. If it was, then rasburicase would have been the right answer. If they asked, how would you have managed this? In this case, we would have probably wanted to manage the hyperkalemia first. So even then, rasburicase might not have been the right answer. But the question would have specifically clued you into what they were asking. Was it asking you about the uric acid component? Was it asking about the hyperkalemia component? Or here it was asking about prevention of the renal dysfunction. And so in this case, allopurinol was the correct answer. So this is really a great example of how to pay very close attention to the question itself, right? And so this is another key learning point in terms of test taking strategy, is to read the question and to focus on what the question itself is asking. And when you're thinking about these answer choices, try to prepare an answer in your mind that addresses this specific question and see if you can find that answer in the answer choices. Because if you don't think about that in advance, if you don't take a few seconds to think about in your head what the correct answer is, then you can get easily distracted by some other answer choices that could be correct if it were a different question on the same scenario. So that wraps up our question of the week, and thanks so much for listening.